Hi, in this module we're going to go over serum renal markers and urinalysis for the laboratory clinical pearl. And one of the things you have to remember is that there are many patients that really have not stepped into allopathic healthcare for many, many years, and they don't know they have a kidney disorder. Obviously, there's kidney conditions. There's lots of symptoms, like if someone has a kidney stone or someone has a kidney infection. There's some clear symptoms, but there's many people that have subtle renal failure. Like there's lots of cases of idiopathic glomerulonephritis where people just develop kidney autoimmune diseases. There are people that have diabetes that progress into renal failure, and that happens all the time. So I really want to make sure you are clear with how to look at renal markers, and they're part of most routine lab tests that get done with a comprehensive metabolic profile. And a lot of times you'll see urinalysis. I just have a really some nice charts I put together to really review the different things you will see on urinalysis related to appearance and the different markers on the urinalysis test, and then how to look at proteinuria and glomerular filtration rate together to really determine what stage of kidney disease they have. And for the most part, when you identify they have kidney disease, they really should be managed by a nephrologist. Many times, once you identify kidney disease, biopsies will be required to really come up with some of the diagnoses. But they're pretty common. I can tell you, just this past year, my neighbor developed autoimmune kidney disease and died within a 2-year period. Also within this year, one of my good friends that I've known for over 15 years, the functional medicine practitioner, within a very short period of time, within a year, was doing fine. All of a sudden developed autoimmune kidney disease and passed away. And if you're working with lots of chronic patients, there are many people that develop autoimmune kidney disease. If you're working with patients with lupus, you'll see some of those markers. And then you'll just see some people that have just idiopathic reasons why their kidneys are starting to fail. And in any case, you don't want this to be a factor that has an impact on your diagnosis. So this is why we're just looking at routine blood tests are pretty important. Most of the patients that are chronic that have walked into the healthcare system have typically had some lab markers done. So usually you don't even have to run lab markers. Many patients will walk in with them. But there's such gross incompetence in the healthcare system today that you'll see patients that have various stages of liver failure, liver disease, diabetes, all types of conditions, including kidney diseases that just get overlooked in the healthcare system. So remember, the kidneys are really important. They regulate acid-base balance, they regulate electrolytes, they help with regulation of extracellular fluids and blood pressure. So when the kidneys are not functioning well, you could have diverse neurological symptoms as the electrolyte concentrations are involved, anything from delirium to muscle contractions and buzzing sensations and vertigo and delirium and cognitive decline and swelling of their legs, hypertensive crises like severe hypotension or severe hypertension, hypertensive headaches, all types of things that can happen when they're not functioning well. So the first diagram I want to go over with you is just when you go into the basics of evaluating renal function, we have symptoms. Urination frequency is important. Pain with urination, always have to consider. Infection. Urine color is really important. Urine appearance, urine smell, and if they're not urinating at all, that's a major symptom as well. So the lab markers that we'll go over will be creatinine, glomerular filtration rate, which is GFR, blood urine nitrogen, BUN, phosphorus, electrolytes, cystatin C, and the BN to creatinine ratio. And then we'll look at the urinalysis and all the different biomarkers of the urinalysis. And then there's also other urine markers like 24-hour urine microalbumin, which is really important to check with the diabetics. And you can also do 24-hour collections of urine for people you suspect may have a kidney stone. And for the most part, in a functional medicine practice, as soon as or any kind of practice, as soon as you see someone has any significant signs of kidney disease, they should be referred out to a nephrologist. But now you know that their kidney disease may be part of their symptoms that could be very diverse and complex. So when you look at serum renal markers, the most important one is really the glomerular filtration rate. And glomerular filtration rate, you see a chart here in the different stages of them. But when you really look at what's happening here is the liver makes creatine, the muscles, the creatine then goes to the muscles will convert to creatinine, and then this creatinine is cleared by the kidneys. So that's a normal process. Liver production of creatine. Creatine is then converted in the muscles to creatinine, and then creatinine has to be cleared out. Creatinine levels may be impacted by muscle volume, muscle breakdown, or in some cases, creatinine supplementations may even do it, especially right before the collection of urine, the collection of serum samples. So if you see someone who has like lots of muscle mass, you can have a slight elevation of the GFR. So someone who has very little muscle mass, you can see that their creatinine levels may be impacted by that as well. So if you're someone like very elderly and just has lost lots of muscle mass, you might see lower levels of creatinine as well. Another marker that's used is cystatin C, which is not impacted by muscle volume and breakdown. So this is something that's not part of a routine blood test, but if you suspect that you may be seeing an abnormal creatinine level or abnormal glomerular filtration rate, but specifically creatinine, if there is a muscle volume issue, then you can always look at cystatin C. And diet, chloride, sodium, potassium, phosphorus, these are things that are helping with normal renal function, but they shouldn't cause any changes in your laboratory markers unless they have kidney disease. And if they have kidney disease, then sodium can really throw things off, and same with high amounts of potassium and so forth. But for the average person, they're consuming electrolytes that the kidneys are modulating, the liver is making creatine, the muscles are making creatinine, the liver is making urea. These are then being cleared out by the kidneys, and then these things all kind of summarize together to become the glomerular filtration rate. Now, if someone has some type of impaired renal function, you're going to be looking at the GFR rate, and you're going to look at the glomerular filtration rate. It's typically going to be low because they can't filter things that well. Their blood urea nitrogen is going to be high because there'll be higher amounts of urea in the blood. They can't clear it out. Creatinine levels are going to be high because the livers can't clear those out. And then electrolytes like sodium, phosphorus, potassium, chloride, these levels are also going to be high. So this is, whenever you see this pattern here, this is a strong indication that there's a red flag, something's happening with their kidneys. Now, if you look at the GFR, you don't know what stage of kidney disease they have unless first of all you confirm that they have proteinuria, that they have proteins in their urine. Now, the biggest clinical clue that if someone has proteinuria is they have very foamy urine. So you may have noticed at times with your own urine that if you had a really high protein meal, that it's really foamy. Now, people that have excessive foamy urine is a big sign that they have proteinuria. So it's one of the things you should always ask a patient about, or if a patient tells you that they have lots of foam in the urine than usual, you definitely want to make sure that they don't have any kidney issues. And if they have proteinuria, meaning they have positive proteins on the urinalysis, and their GFR is greater than 90, that's stage 1 kidney disease, and then stage 2 kidney disease is if the GFR is 60 to 89 plus proteinuria. Then once they get into GFR of 30 to 59, it's very clear that they have renal disease at this point. And, this is definitely, once they start getting into stage 2, going to stage 3, they need to really be working with a nephrologist and being managed properly at that point. And just basically having their electrolytes managed and dialysis at that point, and making sure that they don't have any kind of seizure activity or abnormal electrolyte imbalances or acid-base imbalances that can really cause some severe complications. Now, the other thing that you want to look at is the BUN creatinine ratio. So creatinine filtered by the kidneys, and then you have the production of blood urea and nitrogen. Then the system here is absorbed, nitrogen is produced, and some of these end products are excreted out of the urine. But when you look at the BUN to creatinine ratio, normal is 10 to 1 to 20 to 1. If it's greater than 20 to 1, then you're definitely thinking of congestive heart failure or serious dehydration or serious bleeding. You're probably not going to see these in a functional medicine practice, but if you have someone's medical file when they're in the hospital with something very serious going on, like a severely dehydrated congestive heart failure, you see levels that high. And if the levels are less than 10 to 1, then you're looking at some kind of renal damage. That's of concern. So those are the key things you should be aware of when you're looking at the the renal markers. Most important ones are looking at GFR and BUN. And if you see these abnormal, there's immediately a red flag. And then you can look at and if they do have protein in the urine with a urinalysis, if they're in the early stages of impaired renal function, you'll see these GFR levels that are involved, and then you see them going downhill from there. Now, when you look at the urinalysis, and if you guys do routine blood work, I mean, adding a urinalysis is typically like somewhere between $5 to $10 to get completed. And then there's different markers on the urinalysis that I want to go over here. We'll go through all the different colors, and we'll go through all the different markers. But one of the key things on the urinalysis would be specific gravity. And normal specific gravity is 1.005 to 1.030. So sometimes you'll have people within this normal reference range, but a little bit higher in this 1.02 range. You'll see that with dehydration. So just be aware of that. A lot of times when patients are fasting to get their blood drawn, they don't drink enough water. You definitely want to encourage your patients, even though that they're fasting for the blood test, to drink water. Or if they know they can drink coffee before the blood test and not be hungry, or tea, sometimes they'll just have a diuretic and they get dehydrated. You can see some slight changes of the specific gravity greater than 1.02. Now, if you see the specific gravity less than 1.005, here's the list of concerns here. Definitely impaired renal function is an issue. Diuretic use you'll see with many patients with high blood pressure medications. And if you start to see their specific gravity elevated greater than 1.03, you're really looking at diabetes and something that's more serious. Then you can look at the urinalysis pH evaluation. And then in the pathological range, you can look at the serum markers, and if they, again, like we talked about, GFR is low, BUN's high, creatinine's high, phosphorus high, and there's protein in the urine, you have renal dysfunction. And if you look at their pH and they're outside the pathological range and they have pain, when in the back, this flank pain, you definitely think about a kidney stone that could be involved. And if they have pain when they urinate, you definitely want to be thinking about white blood cells, or if they have foul-smelling urine, that they may have a urinary tract infection. And those things can definitely progress into kidney infections. Now, you can look at functional ranges of pH too. Greater than 7.8, electrolyte imbalances, pH buffering system, alkaline diet with supplements. Less than 7.2, acidic diet, pH buffering system imbalances, electrolyte imbalances. So you can have these slight little alterations. For most people, what they'll need is things like potassium bicarbonate to really balance out their electrolytes. Sometimes they'll need some salt. Usually people that have low blood pressure need salt. People that have higher blood pressures will do better with things like potassium bicarbonate. And bicarbonate will just act as a buffering system to deal with this acid-alkaline imbalance. Over-the-counter, easy supplement to use. Now, I made a chart for you here that just goes into the appearance that you'll see on a urinalysis. One part of the urinalysis will be what's their appearance. So, yellow, amber is normal, and then you can have cloudy appearances. And cloudy appearances, you're looking at a list of possibilities. Excess phosphates, like if they have kidney disease, or excess lipids if they have the kidney disease, excess pus if they have infection, excess chilies if they have things like parasites, excess oxalates with kidney stones, excess purines with high purine diet. So cloudy appearance could be many things. You'll have to look at your lab renal markers and the other markers on the urinalysis to get a clue of what's going on. And we'll go over those in a second. Brown urine, you're definitely thinking of muscle trauma, muscle breakdown. Sometimes people are on statins. If their muscle starts to break down, all that excessive creatinine get in the urine, and myoglobin will get in the urine, and that'll make that urine brown. Sometimes diets, for some people, genetically, they have a hard time processing fava beans. They'll have browner urine, and they'll be very specific to their diet. And then some people that have hemolytic anemia or severe liver disease have elevated levels of bilirubin. Bilirubin will turn the urine a little bit brown as well, too. So those are the main things that cause the brown color of urine. Orange urine, it can also be elevated bilirubin. So bilirubin can make the urine brown or orange. Medications. And then if you have a red color, you can also have muscle breakdown. So red, brownish, you're looking at muscle breakdown or bilirubin. So having a blood test where you're looking at serum creatinine levels. You're looking at even like creatinine kinase to see if the muscles are breaking down on blood tests can be very useful, and then some dietary things that may cause it. And then for brown black, you're always, the worst scenario would be melanoma, but then you see bilirubin again and so forth. And with bilirubin, if you see these changes in urine color, you definitely want to measure on your blood work if you already have direct and indirect bilirubin to then see how to narrow down the list of diagnosis, whether direct is involved or indirect is involved, and so on. Okay. Now, the other key things on the renal marker would be glucose. You definitely don't want to see elevated glucose on the urinalysis. That's, concern for diabetes, more common than anything else. Elevated nitrates, bacterial infection, any kind of occult blood. You're definitely worried about something injuring the urinary tract. High proteins, renal disease. This is the one that sets a stage up for foamy urine, and also this proteinuria, proteins in the urine, plus glomerular filtration rate levels that are low start to classify a patient into renal disease. And you're going to see lots of patients that have ketones, especially if they've been fasting for a while, and so forth. You also see a lot of patients that think they're in a ketogenic diet, and then they get their urinary ketones done. They may not be in ketosis, so that's something also to consider. And then if there is, if they do a microscopic examination of urine, whether it's, leukocytes in there for inflammation or infection, or crystals in there for renal stones, or orange color or fatty cast, you have a chart that really goes over this. Now, when you have the laboratory markers, so when you have like the urinalysis, and you can look at the appearance, you can look at the pH, you can look at the white blood cells, you can look at things like bilirubin, you have all the different markers in the urinalysis evaluated in combination with these routine markers on a comprehensive metabolic profile for kidney disease. It's very easy to identify red flags for kidney disease. Now, when someone that has kidney disease, you got to remember, you have to consider diets like the DASH diet, where their sodium levels are restricted, and you also want to be very careful with giving high amounts of protein in there. You definitely don't want to give them like a high protein shake every day, and they're having a hard time processing proteins and salt. So you're definitely going to be looking at strategies for the DASH diet. If you're not familiar with the DASH diet, I just put this chart for you. And usually when the kidneys get to the point where they're not functioning well, many times you'll see hypertensive patterns that are involved. And especially when you see hypertension with kidney disease, you definitely want to have a person eating much more healthy, potassium-rich foods and foods that are low in sodium. Those are the main things that you want to do. So these are just the recommendations on a DASH diet. So just make sure as a clinician you know how to identify renal markers. Remember, the key things will be the symptomatic concerns would be they have flank back pain that they can't identify. You're always thinking kidney stones with that. Pain with urination, you're always thinking, bladder infection, kidney infection. And then sometimes if you just see like swelling and changes in blood pressure or abnormal neurological symptoms and delirium and acute onset of movements or seizure activity or any kind of imbalance like that, that this doesn't make any sense. You're always considering acid base or electrolyte imbalances associated with kidney disease, and make sure you get those renal markers checked. Remember that the referral pain for the kidneys are just, this is the front and back. So all the way across the back from the 12th rib to the iliac crest and all the way around the front, they can just get referral pain in these areas as well. So it's not uncommon to see this. Okay, I hope you found this clinical pearl useful, and just, make sure you sharpen your skills of knowing some of these charts, and you for sure will find many, many people that have renal markers and urinalysis abnormalities when you're working with chronic patients.